Good morning, everybody, and welcome back to our second day. I am honored to be able to moderate this session. This is near and dear to my heart. Next slide, please. I wanted to give a brief introduction to this topic. If we asked every single one of you what a disaster means to you, we'd probably get quite a few different answers. But this is actually the disaster definition from the Joint Commission. And it's a disaster is a type of emergency that, due to its complexity, scope, or duration, threatens the organization's capabilities and requires outside assistance to sustain patient care, safety, or security functions. Over the last decade, we have seen unprecedented increases in the frequency and intensity of all of our disasters, superstorms, earthquakes, mass shootings, and in California, wildfires over the last 3 years that have really devastated our regions and our hospitals in having to evacuate with very little notice. These disasters really highlight the need for disaster planning at all levels, and especially our OB, neonatal, pediatric populations are really special, need a lot of special considerations. So this panel is really, they're just leaders in this field as far as really being able to regionalize and collaborate with hospitals all over the state and hopefully further to come up with a plan so that the next time we have a disaster, we're going to be better prepared. So I'm going to turn it over to Chris Newton at this time. Dr. Newton will take it away and then we'll move down the list. Thank you.
Great, thanks Nancy. And I'm so glad you put up the definition of disaster, because the details wrapped up in that definition are profound and poignant to think about as we talk about some of this stuff. Next slide. So I want to begin a little bit with just setting up perspectives and expectations for this panel and kind of how we put this together. So my name is Chris Newton, as said. I'm a trauma surgeon. I work at Oakland Children's. I happen to also be the principal investigator for a federally funded program that really establishes a collaborative across all of the West Coast that is specific to problems for kids and mothers in disasters. So as part of that collaborative, Dr. Cohen and Dr. Daniels have been passionate and active participants, and I'm so grateful that we kind of pulled the whole team together. So we set this up really intentionally to talk about, number one, kids, and I will take this and I really want to give big general overview perspectives here. And then Ron, of course, will talk about babies, and Kay will take the perspectives for mothers. So next slide. And expectations, I want people to wrap their mind around that. Going through the details of this, we could spend an entire week of a conference going over all of the work and the details and the products and the focus groups that we've been doing, and clearly that's not the point of this talk. So there will be a lot of general concepts that I want to put out there. You'll get some details, but more importantly, I want to inspire people to look at this deeper and give you resources and where to go and how to connect. So so I will intentionally begin here for a few minutes talking about why looking at special populations matters and why we do this in the first place. And then I want to give a handful of just examples of why kids or mothers matter in your planning process. And at the end, the giving you some resources. I may not get through all those slides, and I apologize for that. But if my time is running out, I'll I'll stop and hand it off. But I wanted the resources on the slides for people to take a look at. All right, next slide. So let's talk first about just general concepts in any given disaster, whether it's a shooting or an earthquake or a hurricane or a pandemic. The first question for our purposes is asking exactly how bad is the impact for the system in terms of kids or mothers. And one would say, oh, it's the same as the general population. Next slide. And the general population of kids make up about 24%, depending on which community you're talking about. It goes up and down just a little bit. I listed a few events there. As you scroll through that, you quickly begin to appreciate that the numbers associated with each of those events is a little skewed. And not uncommonly, children are disproportionately impacted. Now, what the impact is becomes an interesting discussion. So next slide. You can look at all these different events and they all are different in terms of their challenges and impact. It's very hard to compare an earthquake or a hurricane to an active shooter event, especially when you begin to consider the time course. However, some of the things I'm going to advocate in thinking about in terms of planning and preparation and actually taking care of the population that's been impacted is not only do you have to think about the number, so you're 24% of the population, you have to think about the time. If the event has ripple waves that last for weeks and you have food and water and infection issues weeks down the road, that's an entirely different paradigm to consider. Then you have to think about exactly what your community has in terms of resilience. And this is how many hospitals do you have? How much backup do you have? How can you flex and accommodate for whatever the need is? Doing this exercise of talking about what is the impact and how much can you absorb and what can you do, this is a hazards vulnerability analysis that you can do in each area. Every single area, every community, every event, it's all different. You cannot necessarily approach this with a cookie cutter kind of a plan. So these general concepts of things to think about become important. All right, next slide. All right, so I'm going to go over, for kids in particular, a lot of these big concepts. And like I said, I'm not going to get into the details, and that's kind of on purpose. So number one, big general disaster planning concept. If you're creating a plan for a site or a city or a region, the overriding concept is you are trying to help as many as you can. And it's looking at big population, the needs of the entire community kind of override the plans rather than the needs of an individual. This is very different than day-to-day operations and makes everybody very uncomfortable, especially when you're talking about a child. Because this concept of looking at the whole community kind of falls apart when you're talking about a kid for a lot of reasons. And hopefully some of that's obvious. Okay, next slide. All right, anxiety point number one. In any given event, there's typically a triage area lined up in the parking lot, and there's a system that emergency room docs and paramedics that go through to triage and to prioritize everybody. This is all very regimented. People get trained on this, but once again, when you come to kids, this becomes a challenge. Lots of effort has gone in the past of trying to fine tune this specifically for kids. This is one of the, one of the efforts, this SALT triage system. You will notice this triangle right in this graph that is this pediatric assessment triangle. I refer you to take a look at this in more detail on your own time. But the concept is to make this simple, even for a child who can't speak. Are they alert? Can they breathe? Are they bleeding? And that triangle becomes your tool to do your best to, to put them in a category of prioritization. All right, next slide. Okay, anxiety point number 2. Every hospital, every system, when you're beginning to make plans and to actually deal with one of these events, there's three issues that we all think about. Space and where you're going to put folks, stuff. So do you have the right equipment? And staff. Do you have people that are trained to do what they need to? When you look at each of these for kids or mothers, there's special challenges that are different than the rest of the population. For kids, this becomes obvious. You need tubes and ET tubes and ventilators and things like this that can accommodate down to a different size human being. This gives a lot of anxiety because not every hospital is equally equipped. You have to consider this when you're making all your plans. Next slide. Okay, anxiety point number 2. In those 3 things, the space, staff, and stuff, if you're talking about the staff and the individuals, there's a limited number of pediatric specific experts that can really do high level tertiary stuff. On day-to-day basis, this would be unacceptable to not have the right tertiary specialist. In situations like this, you may have to flex and you may have to be creative about who's taking care of the kid. And this gets into discussions about day-to-day activities and cross-training and having every hospital ready on some level all the time. It's a big part of the planning and big part of this. All right, now, next. There it goes. All right. Last, couple of big concepts or a few here. So in any individual event, in terms of your planning, when you're creating, where do I triage the kids? Where do I bring them through the ER, get to the OR? Where are my resources limited? Who's going to be taking care of all of these? Are we going to transport out or stay and do the best we can? Consideration number 1. Kids frequently come with another human. It's uncommon for them to come alone. You will be forced with a situation where you have a parent, caregiver, adult of some kind that is attached to the child that does not want to unattach themselves for any reason. This means your system has to have flexibility to treat both of them simultaneously as best you can. Sometimes you can't do this, and sometimes there's no choice, but wherever you can, the system wants to be able to take care of the mother and the kid. This means that an adult hospital may need to take care of kids, or a pediatric hospital may need to flex up and be able to take care of an adult, at least in a preliminary fashion. I'll also mention again, I talked about the triage at the beginning and that assessment triangle. And I will mention one statement that really is pervasive in all planning. The expectant category and we can do nothing is an impossible category for a child. And we have it on our list. It's still part of the plans, But when you're actually there, it's so difficult to actually place any kid in that category. And you need to plan for that. Next slide. All right. Next consideration I'm going to give you is the other end of the extreme. So yes, most of the time, all children come with parents, and you need to be flexible to be able to accommodate that. In a disaster, every now and then, parents aren't there for whatever reason. They're injured themselves, they got separated, whatever the story. You also have to plan for the child who can't speak, who doesn't know their phone number or address, and there's no one attached to them, there's no history, and you don't know how to get them replugged in back to their family. They may or may not be injured, but they are nonetheless dependent on the medical infrastructure and the system to take care of them, at least until a better solution can be found. So reunification plans, care plans are all part of the consideration that have to be in your program. All right, next slide. And the last thing I'm going to mention here is this. So, which I think is appropriate when you're thinking about kids and planning for a disaster. And that's the concept that healthcare workers have families too. And in most events, all of the healthcare workers, doctors, nurses, whoever it may be, your number one worry on your heart is your own family. You need to be able to figure out, are they okay? And it's almost impossible to do your job if you can't answer that question. So there should appropriately be campaigns and plans that essential healthcare workers have some kind of home plan or kit or communication pathway to make sure that your own family is taken care of. All right, next slide. So now I'm to the point, I'm going to breeze through these last couple and hopefully protect my time here. But once again, I wanted to add at the end, a couple of resources, and hopefully you can quickly imagine with all these big general concepts that I described, we could delve into each of them in great detail. Okay, resources, and I want to note, and I put this up because Katrina was kind of a watershed event, for this country, especially for kids in disasters. There was so much that did not go so well with Katrina that we learned from. And there's been a lot of changes and passion for changes in federal programs, our program being the latest example. So lots of things that are really good and lots of resources and places to go now to get engaged with this national. Next slide. You will note, this is interesting. Some of the federal plans have not necessarily evolved. So you can see this is the list of acceptable candidates to be aeromedically evac on a federal plane. You will note kids and pregnant mothers are not allowed. Now, of course, they adjust for this depending on the needs of the situation, but it's an illustration that sometimes the federal, cavalry that's coming in to help is not the answer for everything you need. And there is appropriately a lot of effort being put into regional and local infrastructure that can help take care of problems. So look into your local plans. There's healthcare coalitions in every county that have been evolving a whole lot over the past few years to get better and better at this. Next slide. The EMSC Center, you can see the website there. I refer you to that. The PEDS Ready program that is right now this month beginning to evaluate every hospital. This is about getting every hospital taking care of kids every day. I refer you to that. It's a great program. Next slide. This is what I was talking about with the PEDS Ready program. You can see the website and the link there. This is a spectacular program. Every hospital should be doing this. Next slide. And as reference, this is how you reach and get in touch with us. So thank you. Take a look at the slides, and I can answer more questions in depth when we get to that. So I think Nancy is Ron up next?
Yes, he is.
Okay.
All right, everybody there. Good morning. Good to see everybody again. I'm going to do a quick update on train in the neonate. Next slide, please. So what is train? Train was basically a development out of desperation. And about 2008, as we started preparing for bird flu, we got to thinking about what we might do for neonates. And train is a triage tool designed for hospitalized patient movement. It uses resources needs of the patient to determine what kind of transport needs are required to move the patient. And it was created by, well, with all lack of modesty, expert opinion, not meaning me, and aligned with the local EMS protocols. We actually worked with the local EMS directors in our local counties to see how we could work with them for transport. Next slide, please. Okay, so it was developed at Stanford. It was initially developed for the neonate. It was then expanded to pediatrics and obstetrics, and is now being moved into the adult hospital too. We've managed to integrate it into both Cerner and multiple Epic sites, and each one is different. It can still be done on paper with some training, and it is now being adopted by multiple organizations around the whole country. Next slide, please. So the basic of the tool is that you score a patient's resource needs, whether they're a kid or an obstetric patient, in 4 basic areas. The areas are slightly different for peds versus OB, and Dr. Daniels will go into that. But we score a patient's resource needs in life support, mobility, nutrition, and pharmacy for the neonate. Next slide, please. And here's the basic algorithm or matrix. And as you can see, we have the 4 categories where we score the patient, and those determine which one of the 5 color-coded on top transport methods the patient falls into. And so patients who are totally stable can go home in a car. Patients who are extremely resource dependent need specialized ambulances that can support specialized equipment. And then you see the BLS, ALS, and critical care in between. Next slide, please. So I'll give you an example of how this works. It works very simply. We'll talk about a hypothetical 6-week-old, 940-gram baby, 25-weeker, had RDS and adductus, was ventilated, given surfactant, has weaned to nasal CPAP with varying levels of oxygen requirement, having apnea, feeding by gavage every 3 hours, and is on oral medications, capsid, vitamins, and iron. And of course, is ready for his first ROP exam at about 31 weeks corrected. Next slide, please. So how would train deal with this kid? Well, it would look at the 4 different domains: life, support, mobility, nutrition, and pharmacy, and see which category the child falls out in. So next slide, please. He's on CPAP, which puts him in moderate. Next slide, please. He's under 1,500 grams, so he ends up in an incubator. His nutrition, next slide, please, is intermittent. And his pharmacy, next slide, please, is all PO. So it's very simple. You go with the most demanding category that you fall into, because you have to have that level of support no matter what the other levels are. So this child needs a specialized ambulance that can handle an incubator. All right, very simple. And the point is, this is so simple that it can easily be done by the electronic medical record. If the nursing notes are done accurately, the EMR knows full well that the baby is on CPAP and in an incubator. Next slide, please. Next, please. There you go. So it is easy to integrate into the EMR and makes it absolutely no burden to the clinical workflow. It is totally non-biased. There is no institutional bias in this. And we know, for instance, and I didn't bring those slides with me, that institutions tend to be biased against babies. The discrete data points from the nursing chart have to be found. So it takes delving into the bowels of your Epic, Cerner, or whoever else's setup to figure out where in the nurse's notes to look for the data. But the data is already in there. Nurses do not have to change what they're doing. But what you do need to do is take the time to teach your EMR or EHR where to look in the data to figure out how to code the child. And it sometimes takes a few iterations to validate that the coding is correct. And I can tell you about some of the mistakes we made. One of them that I indicate here is you can't look at the orders, because it turns out lots of kids have PRN orders for medications they're never on. And that, for instance, might include an insulin drip that is only given if the glucose goes above X or Y, and it's never been used. If you think the kid's on an insulin drip when they're not, they will get upcoded by the computer. So you need to look and see, is the kid actually getting insulin? And that would be clear in the nursing notes if the computer is taught where to look. Next slide, please. Okay, so now that it's in the EMR, EHR, it serves multiple purposes. So we actually print out regularly every shift, not every day, but every shift, copies of the train report in OEM and at the nursing supervisor's desk. It is also given to every charge nurse on every shift. It can be updated at any moment. You can go into it. If your computer is running, you can go in and print out a new report. But even if your computer is down, it was printed out at the start of your shift. So you can have that as a downtime report, and you can do it as a downtime report manually, but it does take some time. Now that it's been available to us, we have found out that it actually is useful on a day-to-day basis. So you can actually look at your unit, and if your unit is shifting to more and more red patients, you might need more personnel. If your unit is full and you see you have a bunch of blue and green patients in an intensive care unit, those are patients you can focus on for moving out of your unit to a lower level care center, to either the floor or the well baby nursery or a nearby level 2 if you're in a level 3. And thus it actually is useful on a day-to-day basis. Next slide, please. So this is what our report looks like. I've obviously blanked out the PHI, no MRNs or emergency contact numbers, but you can see that it prints out every bed, every patient, and their color code with what the color coding means for people who are either colorblind, like me, or are unfamiliar with the tool. Next slide, please. We can also print out an entire hospital report, and this is what the hospital administration wants to see. And they can see how each unit stacks up throughout the whole building. Next slide, please. And this is what I call the money slide. As I've walked around trying to convince people that train could be useful, when I show a slide like this to the OEM director, or a slide like this to a major administrator in charge of these things, their eyes sort of bug out of their heads, and I suddenly get their attention. This wakes them up. So this was just a random day at Packard some time ago. We just ran the tool, and I showed this to administration. And when they realized we needed 61 critical care ambulances and 38 specialized ambulances to evacuate that day, we realized it took about 10 counties worth of equipment to evacuate this one hospital. Suddenly, the value became obvious to the people I was talking to. Suddenly, the need to pay attention to planning for hospital evacuation was driven home. Next slide, please. You can see here, we ran a drill. The state runs a drill every November in California, and we ran this during one of our disaster drills. And what I want you to see is, you can hardly see it there. At the lower left of the graph, there's a little tiny green line. And that's the 48 seconds that it took for the computer to print out the train report for the entire hospital. The yellow bar shows that it took 57 minutes for our people who knew how to do train to do it on paper. The red column, which stopped at 2 hours because the drill lasted 2 hours, was when we called each unit individually and asked them to tell us what their transport needs were. And they were not done at the end of the 2 hours when the drill was done. And so again, this is the wonderful thing about train. It really simplifies, speeds up the entire process if, God forbid, you need to evacuate a building. Next slide, please. Like I said, there are other uses. It is important in regionalization. It would be wonderful if every hospital in your region used the same tool. So when you call from hospital to hospital during a disaster, you don't have to stand there and sign out 228 pediatric patients. You can call up the NICU there and say, I have 5 red neonates. Can you handle that? They instantly know what kind of resources that is, and they can deal with it. So it's useful for evacuation and for patient movement. But like I said, it can also be used to help guide staffing and also create surge capacity. If you get the phone call that your nearby NICU is evacuating and needs beds from you, you clear out your reds and your blues and greens and make room for their reds. So it has lots of uses. Next slide, please. So hopefully we can implement this as a standard and automated inpatient triage system that has minimal to no impact on your daily workflow. It allows us to quickly assess and accurately request the right resources from your emergency command center, and hopefully can streamline communication. If everybody uses the same code, it streamlines communication in a regional disaster. Next slide, please. All right, we are having what we call the Train Consortium within RAPM. And the idea is that all of us who use Train will work together to communicate better with one another in a disaster. And hopefully, as things evolve, if Train needs to change, we will all change it in sync. So we're all using the Train tool the same way. This is being adopted now by multiple places, FEMA and TEX, which is in Texas, as Kay will talk about, multiple NICUs in California, the Sutter system, San Diego County, Central Florida, and so forth. And I think this will become more and more a national standard for regionalization. Next slide, please. All right, so let me just thank the rest of my Train team, Kay, who you'll meet, Anna Lynn, who helped move this to pediatrics, and Christine Taylor, who is our IT support. And if you have any questions, there is our central email. You can reach all of us. Thank you very much, and I'll pass this baton on to Kay. More resources if you need them.
Good morning, everybody. I'm very pleased to be here to talk to you today about safely evacuating an OB patient population. I'd like to start with thanking Ron for developing the Train concept for the NICU and including OB. And also thanks to Chris for asking OB to join his National Pediatric Disaster Group, RAPM, because he gets it, that for a true disaster planning, pregnant women should be included because that's where babies come from. Next slide. One of the overriding issues for OB disaster planning that I learned quickly is to understand that our hospitals don't really understand us. OB is unique in disaster planning. And when you think about it, for us, we're very different than the rest of the hospital. So when a hospital disaster planner starts their plan, each floor pretty much looks similar. Med-surg patients have the same needs. Even the ICU patients pretty much have the same need and are the same acuity level. But that's not true for us. We have a larger variety of acuity than anywhere else in the hospital. We have a large footprint. So we have our laboring women, we have our intra-op and post-op patients, and then again, we have our healthy postpartum patients with their newborns who can just easily get up and go home after a disaster. Because of this range of acuity of care, we have this unique challenge, and we need to be actively involved with any hospital disaster planning because they really don't quite understand it. And then, of course, we also have the unique challenge, next slide, of caring for more than one patient at a time. Again, we're the only place in the hospital that has to deal with this. We either have mom and fetus or mom and her newborn. And without pre-planning for these situations, we may transfer a mom during a disaster that may be best for her, but not her fetus, or vice versa. Or even more specific, next slide, even more specific for OB. How do we make sure mom and baby stay together during a disaster? This challenge is neither simple nor trivial. because seen in Katrina, in some cases, it was 10 days before mom and baby were reunited. Now, this is due to a variety of issues, but likely partially due to the lack of planning in place to assure mom and baby are sent together. Again, this is all, as obstetricians and pediatricians, we know that those 10 days are vital in terms of keeping milk supply and lactation and emotional. So emergency operations need to be cognizant of this issue for obstetrics. We need to make sure they understand this issue. Next slide. So to specifically help with evacuation, we took Ron's NICU model and adapted it to fit OB. We've called the triage tool OB Train. And this tool allows for providers in OB to quickly decide where an OB patient can be moved and what they would need, what resources they would need. Next slide. Just as Ron described, the tool has to be simple, quick, easily done by the bedside nurse or through the EHR if it's available. First, we'll discuss the use of OB Train for AP and L&D patients, and then postpartum, because the parameters are quite different. So this is what the parameters are for AP and L&D patients. You have to know the patient's labor status, whether they can walk, if they have an epidural in place, and finally, including maternal and risk factors. Now, when you look at these parameters, if any of you are L&D nurses or OBs, you know that the bedside nurse can tell you all these answers in 10 seconds or less. And that's what you need for an OB triage tool. Next slide. So this is what OB Train looks like. Has the same transportation colors as Ron described. But if you look, especially, we have a very large area to the right called shelter in place. And this is very important for OB because of what we do on OB. We may have a patient who's intra-op and can't be evacuated, and we're going to have to plan for shelter in place, or someone who's about to deliver. So we won't be able to really transport them until afterwards. So our OB Train looks a tiny bit different than Ron's because of these unique problems. Next slide. Perhaps the easiest way to understand how simple and effective this tool can be is to demonstrate it. So we have a 26-year-old at 40 weeks, and she's in early labor. Go ahead and click slide. Great. And she can walk. She hasn't got an epidural. So slide and slide. Perfect. Next one. And she's basically pretty healthy. Next slide. And baby's healthy too. So you see that even though most of the market, most of the triage is blue, there's one that is green. And as Ron mentioned, you always take the most acute, even if it's only one, because you don't want to send this lady in labor home. But you don't need to rush her in a specialized ambulance either. So next slide. So she can easily go by a BLS ambulance to another hospital where she can deliver. Okay, let's do someone a little more complicated. All right, we have a 32-year-old at 31 weeks with severe preeclampsia undergoing induction of labor. So she's early labor, slide. That makes her a green. She can't walk, slide and slide, because she just got an epidural less than an hour ago. Baby looks okay because we're pretty early. But this is a patient who is requiring IV labetalol for blood pressure control. And she's on continuous magnesium sulfate because she's severely preeclamptic. Slide and slide, go ahead. So she's going to have to go by a specialized ambulance. And this means that either a labor and delivery nurse or an obstetrician will have to accompany her to manage the magnesium sulfate, which, as we all know, is a respiratory depressant if not managed well, or because of intermittent need to give her the labetalol. So that's what L&D type train would work like. Now let's look at postpartum. Slide. So these are the parameters that are obviously different than for L&D. Here you need the delivery type, how long ago they delivered, and whether they can walk, because some of these patients will be post-op, and if there's any maternal risk factors to be included. Okay, next slide. All right, so again, we have the shelter in place that has to be there as well, because you may have some women that are just too ill to be transported. And you're going to have a lot of women who are going to be able to go home via car. So let's do some examples. Okay, so here is a nice, healthy 29-year-old multip at 39 weeks. Oh, I'm sorry, I'm just giving you a complicated one. Okay, this is our 29-year-old at 39 weeks. She had a C-section 8 hours ago. Her course was complicated by chorioamnionitis, and she had a postpartum hemorrhage. So she was a complicated delivery. She is not walking yet. Next slide. And she is post-op by 8 hours. But because of her need for oxytocin, because of her postpartum hemorrhage, and her triple antibiotics for chorio, and we don't have a post-op hematocrit yet on her because she's going to have to be transported before that. She is then considered ALS, advanced life support, so that they can continue monitoring her carefully and continue her antibiotics. Slide. Oh, and baby, in the postpartum, we've included this neonatal status so that we can know where baby goes and potentially send them together. Slide. So she's going to go with her antibiotics going and monitoring because of her anemia. Next slide. Here's what train looks like on the postpartum unit integrated into the EHR. The data is determined, as Ron told you, drawn from the nursing notes, orders, medications, and for OB, we use something called MEWC, MUC, for vital signs. Having it integrated into the EHR allows it to update immediately with any new input. But this can also be done manually. We all know that computers might go down. And so we have provided a trained tool in our disaster box to be able to hand out to each of our nurses and staff if some disaster happened. Next slide. So what's the future look like? Our hope is to advance the use of train on a regional and statewide basis. So we have a common language in a disaster, just like Ron spoke about. Next slide. Next slide. Because communications are essential. Phone lines can be down. So all disaster response is local. Next slide. You need to be able to depend on a pre-existing local collaborative network for 48 to 96 hours. And you can only do that if you have a common language to speak to each hospital in. Next slide. What the future can also look like, if we can accomplish this common code, is what they've done in Texas. Texas has developed what I consider a best practice for disaster planning. They have divided their state into perinatal regions. Next slide. They use train as a common language, and they have adapted this common language and practiced within their regions. Excuse me. Excuse me. Next slide. They even practiced on each site with each other using OB train and NICU train and PEDS train. And by using this common language and practicing together, they're going to be ready for their next disaster. What a great model for all of our states to consider and adapt. Next slide. I'd like to acknowledge the fabulous OB disaster planning team at Stanford listed here. It's a team that consists of nurses, OBs, pediatricians, anesthesiologists, and Office of Emergency Management. Each one who has worked diligently and creatively to create these tools, and without whose work the project would never have succeeded. Next slide. Thank you for your attention. And I've listed here a website you can access that has more information and tools that we developed at Stanford through our disaster planning team, and an email if you have any questions. And now I'll turn it over to Nancy.
Thank you so much, everyone. Such an amazing work that you've done, and has such huge, ability to protect our young ones and our moms and babies that have been overlooked through the regular EMS system for so long. So thank you so much for that. We do have a couple questions. And one I think that is really, really important. I'm sure many people that have been listening to this are asking themselves, how can we get started on this? What should we do first? I'll leave it up to either Kay or Ron to answer this question.
I'll take first stab. I would say the first thing you need to do is to collect a multidisciplinary group. At least for OB, you're going to need an OB anesthesiologist, postpartum nurses, labor and delivery nurses, your Office of Emergency Management, and OB, all sitting at the table together to discuss the plan. Their input is just invaluable from all different angles. And then don't try to do everything at once. Start with development of your disaster box. What do you want in your disaster box? Well, I would think we all acknowledge we would like light. We don't want to deliver babies in the dark. So having things like headlamps and lanterns, and start thinking about other things you might want to have in there. We chose to have vests that had the ability to put our name and what our role was, so that in a disaster, we would know whose role everybody had to play. And then you build from there and get more and more advanced. That's how I would start. Start small and build up. Ron or Chris?
Well, if the question is specifically, an interest in train per se, this is not something that an individual can do. It has to be an institutional decision. One thing that we've done is people like myself, Kay, and others, Chris, come and give talks at hospitals and explain what this is. Kay and I, for instance, gave talks to the Sutter people, and after a few talks and introducing them to the concept, as a group, the Sutter chain decided to enact train. Then there becomes the how-to, the nitty-gritty of how does a hospital chain or an individual hospital roll this out to the entire hospital. And it's a series of educational talks, but it's also making the decision whether you want to integrate it into your EMR, your EHR, and then working that through with the IT people, how to do that. The first step, though, is seeing if there's an institutional interest. And that's where the final slide that I showed you gave the train contact email. And we're happy to come and give talks to institutions to explain what this is all about, sort of a more detailed version of what we just did. And if hospital administration decides to go with the concept, then we work with them to figure out how to incorporate it into their structure, either manually or electronically, frequently manually first, and then expanding it electronically.
Great, thank you. We have another question. I think this probably is for Chris. How important a role does the state play in emergencies in terms of losing compliance or regulations during an emergency?
Well, it's a huge role, and every state is slightly different. Every county is slightly different. So if you're looking in California, for example, a great deal of infrastructure is at the county level, and the state then has help those counties, and they set the rules for how things happen. And if the state needs help, then there are official processes for the state to ask for help for the federal government. However, the system is set up that the federal government respects the jurisdictions of each individual state. This means that very important questions of licensure across state lines, or reciprocity and billing across state lines, or patient movement, or HIPAA, you could go on and on. Those legal issues, when you reach the border of a state, are profound issues, and they do not necessarily go away automatically. So making them loosen, as you say, takes executive orders and disaster declarations. And sometimes it takes MOUs between states. Some states are better at this than others. So you can quickly imagine that the landscape is quite heterogeneous, and the legal challenges are significant. So it's a good question, and the short answer is the states control a lot.
Great, thank you so much. Unfortunately, we don't have any time left, so thank you all very much for your great information. And our next session will be starting momentarily with Dr. Bamble and talking about ultrasound in the NICU. So remember to sign off this and sign back onto hers. And thank you all very much.